And with the development and new equipment, there was an introduction of single chip camera, then came the 3-chip camera, and then there were 3D cameras. Newer and newer features and equipments have been added. And with addition of new procedures, better procedures, there has been more and more mental as well as physical strain on the bodies of the urologist. With developing technologies, new and new robotic platforms have come, and every platform has got its own challenges as far as the ergonomics is concerned. So it is speaking on the hand, spine, and knees of the surgeon. And we all know surgeons need to keep very, very fit to keep them updated with technology, perform the procedure, and deliver the quality. So with the thought process, we are doing this platform, we are doing this seminar today, in which we are going to discuss the ergonomics in urology, how to save and our bodies so that we can perform efficiently and for a long period of time. I think I'll hand it over to Dr. Rishi and the chairman today for the further proceedings. Over to Dr. Rishi.
Thank you, sir. As you have highlighted, this is one of the important aspects for any surgeon actually, and because over the long term, the surgeon needs to take care of his own body also and health. Dr. Umesh has taken all the pains and done the hard work to communicate with all the faculty for this and arrange the program for today. And Dr. Umesh, please, we can start the program now.
Yes, sir. Thank you. Thank you all. And at the outset, I would like to give my regards to NZUSI and especially Dr. Rishi Nair sir for giving this opportunity. This is a very important topic, and so let me share my screen. So my screen is visible?
Yes,
it is.
Okay. So basically, we all know that this is poor ergonomics in the operating room can have detrimental effect on the surgeon's physical, psychological, and economic well-being also. And this problem is of very much importance to urologists because they have basically trained in all type of operating procedures, whether it is open, laparoscopic, robotic, microscopic, and endo-urological surgeries mainly. And these all problems, these all type of operations has their own ergonomic considerations. So vast majority of urologists, they don't have experience of basically how to do these procedures. They do experience, but they ergonomically they don't know how to put themselves into the these positions and do their procedures so that they can avoid work-related musculoskeletal pain or injuries. And it has been seen that this surgical economic in urology ergonomics has been understudied and underemphasized from day to day from ancient time also. So basically this webinar has been focused to highlight several practical recommendations that we can incorporate into practice without interrupting our workflow and also minimizing the injury to the surgeon. So with this, I would like to start with the permission from the NZUSI that this has been designed and basically two parts have been divided. The first part is the introduction to ergonomics in surgery, and these are our chairpersons. So and the speakers are there. So I would like to call upon our chairpersons, Dr. P.N. Dogra, Dr. Ajay Sharma, Dr. Syed Sajid Nazir and Dr. Vikas Agarwal to kindly take the dais and call upon the speaker and start the session.
Okay, thank you. So for the introduction to ergonomics in surgery, I first invite Dr. Hemant Goyal to speak, who is professor and HOD urology in RML Hospital. And Dr. Hemant Goyal, please.
Thank you, sir. I'll just share my screen.
Yeah.
I hope it's visible.
Yes, it is.
Yeah, thank you. Thank you, Dr. Mesh. And I thank the entire Northern USA to take up this very important topic. Together, me and Dr. Ramesh were discussing for last 1 year because we both are 10-year post MCH and we both are experiencing these type of injuries. And after this only, we thought we should have more discussion regarding these type of musculoskeletal injuries or musculoskeletal disorders. So my topic is work-related musculoskeletal disorders among surgeons and training. So, what is musculoskeletal disorder? It is a mismatch between external load and the capacity of the human body to resist biomechanical and physiological strain. It is the magnitude, duration, and frequency of loading, as well as the time for recovery, which determine the physiological effect. It is an anaerobic process because of constant use of a muscle. There is an anaerobic process which produces lactate, and this can cause harmful reaction resulting to internal failures within the cell. In tendons, continuous loading can also cause cell damage. If the exposure continues, the damage will continue, and the result can be inflammation of the tissues, excessive production of fibrous tissue, and pathological morphological changes of the tissue. There can be nerve entrapment, which can lead to a lot of symptoms. Very commonly, we experience pain, numbness, bundling, tingling sensation, tenderness, swelling, muscle spasm, muscle weakness, clumsiness. We all think that this usually comes 5 to 10 years post of our MCA passing of MCA because that is the time we are doing a lot of laparoscopy, endourology, now robotic surgery, and we think that these symptoms are age-related symptoms. But actually, these are not age-related symptoms. These are symptoms because of constant use of particular muscles. MSD and surgeons' poor ergonomics in the operating room can have detrimental effect on a surgeon's physical, psychological, and economic well-being. The laparoscopic approach that has become the standard of care for many surgical intervention due to its benefits compared with open surgery, which include less post-operative pain, faster recovery, shorter hospital stay, and improved cosmetic results. But it may increase the physical workload of the surgeon, and these injuries are real and these are preventable. But to diagnose and treatment is very difficult. MSD and surgeons, the risk factor includes static body posture, repeated upper extremity movement, force exertion from adverse position. Workload is increased by the high level of task precision and time pressure. Recent studies report musculoskeletal disorder prevalence rate of 73% to 88% among specialists in MIS, and this is a very staggering number. And a lot of research has been done, but this is very infrequently discussed because we are mostly discussing about patient and not surgeon. MSD is developed gradually and can affect different part of the musculoskeletal system, including muscle, joints, and nerves. Laparoscopic surgeons mainly report issues involving their neck, back, shoulder, wrist, and thumb. Symptoms associated with these MSDs predominantly include fatigue, pain, stiffness, numbness, can affect task accuracy, and the potentially having an indirect impact on patient safety. Surgical performance was negatively affected by their own injury or pain, influenced their choice of operative procedure. I also do radical perineal prostatectomy, lap radical prostatectomy. In the morning, if I am not feeling good, I'll do a perineal prostatectomy. If I am feeling very energetic, then only I do a lap radical prostatectomy because it takes a lot of effort as surgeon. Laparoscopic instruments also they have a one size fits all handle. They are not customized for a small hand, medium hand, or large hand like gloves. And previous studies they report that such handles are less comfortable for surgeons with small glove size. If we take for an example radical prostatectomy, which is one of the most strenuous surgery, whether it's open laparoscopic or robotic assisted surgery technique. So open radical prostatectomy, this requires the urologist to flex his neck inferiorly and caudally for the duration of the procedure. Open surgical procedure generally have a forward blessed back. Excuse me. They have a forward flexed back, which is normally more than 15 degree, and neck that allows them to lean over the operating field to look inferiorly into the deep operating space. So there is a more flexed back and there is more flexed neck, which can cause you back problem and neck problem. Whereas in laparoscopic radical prostatectomy, surgeon will focus their attention on the eye level visualization monitor, which result in a relatively extended back and neck. That is also a problem for a prolonged period of time. Hand paresthesia, restricted range of motion, and the hands and wrists are prone to excessive stimulation and ulnar deviation to grip the instrument. That is the most common complaint during and after laparoscopy. Shoulder pains, ports are placed on both sides of the midline, and operating work necessitates reaching over the patient and across the midline, which add to your shoulder pain. Neck pain because of hyperextended neck to look at the video display. Lower back pain because back and torso are topped towards the pelvis. Robotic assisted radical prostatectomy will be taken care in subsequent lectures. Now, ergonomic consideration, neck or back pain was experienced in 50%, 56%, and 23% of the surgeon after open laparoscopic and robotic assisted prostatectomy. 17% of the doctors are taking non-steroidal anti-inflammatory agent for prophylaxis or relief when operating. In conclusion, these MSG's prevalence among surgeons performing MIS is likely higher than is commonly acknowledged. Operating table has a very important role to do, because if it is a higher or lower, if it is higher, operating surface heights more than 80% of the elbow height, then it causes abduction of the shoulder more than 30% and ulnar deviation of the wrist, leading to discomfort in the wrist, shoulder, and neck. Whereas if it is lower height, force the operator to increase back flexion more than 25 degree, which correlate with the worsening back pain. The problem is the height of the main surgeon and the assistant surgeon, which is usually a trainee or resident, they don't match. So we cannot have two different height of the table. So what we have to equalize the height of the surgeon and the assistant by having some sort of height extender in the OT, which can be given to a lower height surgeon or trainee. Monitor placement is very important. Optical monitor position is directly in front of the surgeon, and the distance should be 18 to 120 centimeter. Again, if it is more than that or less than that, can have detrimental effect to both the surgeon as well as to the assistant. The ergonomics will be discussed in subsequent lectures. Also, there is very important to equalize your body weight onto the surface. Again, if you are surfing surface, your footwear is not good, you are not using an anti-fatigue cushion floor mats, and you are doing surgery for more than 4 hours, then that will have detrimental effect on again your hip, knee joint, ankle joint. Endourological procedures also, this very important is to have optimal position of display monitors, which should be positioned directly in front of the surgeon. Mostly they are on right side or left side of the surgeon. Again, there is a stress to the neck, shoulders, everything. So that adds to your musculoskeletal disorder. It can avoid excessive axial and sagittal rotation of the neck and back. Again, endourological procedure during flexible cystoscopy and ureteroscopy, which is very common nowadays, the instrument should be held at surgeon's midline and more acute elbow angle. Primarily engage the wrist and finger muscles to maneuver the flexible scope and avoid extraneous upper extremity movements, and typically reduce the efficiency of movement at the working end of the scope. Endourological procedure, again, seated position should be adopted during endoscopy to reduce the muscle fatigue and strain on the lower extremity and avoid unilateral weight bearing when operating foot pedal. So important is your weight should be the center of weight should go down, and it should not be the weight should not fall on one side of the body, right side or left side, for long duration. That will add to the injury to your hip and knee. Recommendation for optimal use of foot pedal is also very important. There are proper recommendation. They include limiting dorsiflexion of the foot above the pedal to less than 25 degrees. Lead aprons are very important. In our time, it was only single piece lead apron. Use of lead apron more than 10 hours per week has been associated with the increased risk of low back pain. Utilizing a 2-piece apron is advised. So in summary, it is a need of our to talk about our pain, our injuries. A healthy urologist and surgeon can only give consistent long-term good result to their patient. Ignorance is biggest cause of these musculoskeletal disorders. These are easily preventable, but they are difficult to diagnose and treat. And it is very important to inculcate these healthy habits in a residence, because at the time of residency, they don't realize it. We also never realized it. But after 10 years of our MCH, this has gradually built on, and now they are very difficult to diagnose and treat. Thank you.
Very nicely covered. Practically, you have covered all from top to bottom, all kind of strains, I would say, not injuries, because strain ultimately convert into injuries, repeated strains and all that. So one important point, when I used to do radical prostatectomy, I also realized that you all the time you are standing on one foot, usually the right foot, because you are twisting and looking into towards the working on in the pelvis and seeing the monitor in between the legs. So weight distribution is a very, very big factor. So I think we have where is the list of that thing? Second speaker. I'm not
So
able to
second
see that.
is Dr. Aditya Sharma, PCNL and
Is he
surgeons.
William?
Is Aditya is there?
He was traveling, I think.
Umesh?
Aditya was traveling, he said.
Anyhow, I think we move with the next talk by Dr. Harshit, robotic surgery, while we sort out the issue with the Dr. Aditya's talk. Dr. Harshit is there.
Thank you. Thank you, North Zone. Thank you, Dr. Singh, Dr. Rishinaya, Dr. Umesh, and everyone for giving this opportunity to present. I think I made a similar talk in the last North Zone meeting, and from where I think this talk drives an inspiration from. So, I think Dr. Hemant Goel sir has covered a lot and he has given a brief of everything. So now since the robotic is advancing, now, apart from Da Vinci, we have the other robots as well. So this becomes very pertinent and we'll talk about the robotic surgery and ergonomics. What are the best practices? I have a disclosure that I've predominantly used the Da Vinci XI console and I have an idea about the other consoles, but it's mainly based on the XI. So before I start, I'll just give you a story, a very landmark example. So this was one of the most powerful aircrafts, which was, designed by the USA in World War II. It was called Boeing B-17 or, flying fortress. So it can, it can pump thousands of bombs at once. And it was very aesthetic design, very powerful. US was very, proud of, and Europe was very envious for, for this particular aircraft. But what was happening, it was doing a good job when it goes to field, destroying the bunkers in the German and Nazi camps. But when it used to come back and land, it used to have these, multiple errors and embarrassing accidents. Very, it was going well. And as soon as it's a time to push the runway, touch the runway, it just collapses and, it skids out. And every time it was said, pilot is error because it's exhausted, he has gone, and it's not, nothing is wrong with the machine per se. And then they hired a psychologist, which they generally have in the Air Force, and one of the interns was there with them, and they tried to interview what is really happening with these, errors. Why is this so much common? Why is this such a powerful aircraft getting again and again fatal accidents? And what they realized is the two gears, which were, landing gear and the wing flaps. So one which was supposed to be pressed during the landing and one which was supposed to press takeoff. They were lying. And instead, and they had a similar design, so pilots would accidentally press the wrong gear, and that is why this would happen. And then after that, they actually decided to change the knobs of various levers, and that almost led them to become the founding fathers of ergonomics, especially in the aviation industry. And so we always say to design the machines to accommodate the human behavior instead of retraining the human behavior to fit the machines. And that is what ergonomics is. And we all think that we might know a little bit, and sometimes with a maybe not. And so here we are. Ergonomics, as already said by Dr. Hemant, it's basically an interface between the man and the machine. We are mainly here talking about physical ergonomics. And this was a picture I took from, no, nothing personal here, just from Facebook. Someone was sharing on one of the Facebook groups, did a radical cystectomy, wonderfully robotic. But I just want to show this, highlight this picture, posture, what, it is something, he might have designed, it did a very good job, but it was not ergonomically sustainable, especially doing radical cystectomies robotically with such odd posture. Long surgeries would take a heavy toll on our health. And so the problem is that we don't understand the problem. We always try to adapt the worker to the environment rather than the environment to the worker. And we all think that this is our, part of the job. And so with this, as the world got more advanced and doctors got more aware, we even have a surgical ergonomic society in states, and surgical ergonomics for urologists was a practical guide published in Nature in 2021, where they basically said, in open lap and robotic surgery, which are the key organs which get have pain or get a heavy toll during the surgery. Now, coming back to the robotic surgery, as the topic for me is for robotic surgery. So robot, has all these advantages of motion scaling, tremor reduction, improved visualization, dexterity, more degrees of freedom, and was supposed to have the one of best ergonomic workstations. And that is true, with ergonomics and robotics, with sitting position, chair and armrest, weight bearing, as already mentioned, in the last talk, where when doing laparoscopy, standing on one foot is a key, which is causing heavy toll on the spine. So when you are sitting, so that weight bearing is taken care of. You have adjustable stereo mirror where you can operate, and your camera is in your control, so you have a visual motor axis, which is under your control. But and so it is superior to the ergonomically than laparoscopic for less pain in the arm and shoulders, but it's not perfect. Even, this was a survey published, one of the largest surveys on robotic surgeons. It's a published surgical endoscopy, and predominantly by the group from Hopkins. So the 56% of the robotic surgeons still had physical symptoms, predominantly of the neck and the fingers. And as urologists are the most prominent specialty doing the robotics, so the urology had the highest from the major fraction of suffering from this pain. So we realized we have a problem. And when Da Vinci was designing, and as the industry was designing about the robotics ergonomics, they thought of cytopathologists. So effectively, all the guidelines which we are talking for the ergonomics in robotics are derived from the cytopathologist, because essentially he's also sitting, and they also have a closed console, something like that, or seeing in a microscope. So a lot of posture things have been adopted from cytopathologists for robotic surgeons. This is the key slide. If we can spend a minute or two on this slide in particular. So when we are sitting, because we are not in physical, so I would generally love to demonstrate how exactly we should sit and take care of it. These are very small things, but especially we should take care of them, especially when we are doing surgeries like robotic cystectomy or a tumor thrombectomy, which are RPLNDs, long surgeries. So normally, our spine, it has been normally when you're driving a car or anything, our spine is the one which cervical spine is the one which gets take the heavy toll. Now, especially in this closed console, we have to make sure that, we are engaged in that console, and we have an option to adjust our viewer, but we sometimes fail to realize how our viewer should be, ideally positioned. So grossly, we should remember that instead of straight gaze, up to little bit, we should not flex a lot, and we should not hyperextend. So we have a zone of a 30-degree flexion. So our neck should be within that 0 to 30 degree of the flexion. That gives the optimal position for that robotic surgery. Second is when you're operating, because especially this happens with the trainees, this gets some time to sit on the console, and they just want to do something, and they really don't bother about the ergonomics at that time. So your hands, they should be at around 90 to 120 degree. So the elbow angle, it should not be over or should not be under. Mostly what happens is we squeeze our body tight, and we're trying to operate, and that causes a lot of pain in the shoulders and the elbow. The third thing which we always notice is the legs. So we can always adjust our leg pain, so that we can have the cautery and the camera control. And so don't hyperextend your knee, and don't hyperflex. Normally we're having hyperextension because we don't pull it sufficiently enough to our side. And so ultimately our back muscles, our gluteus is in a lot of pain, chronic extension of the knee. And the third thing, when we are sitting, so many a times we are operating and we don't realize, and we have called something called a working envelope, but we are not working in that, but we are moving out, and we are abducting our shoulders. When we abduct our shoulders, more than of 20, 30 degree, and sometimes goes more than 60 even. At that time, our shoulder muscles are in a lot of pain, especially supraspinatus and the cuff, rotator cuff. And that causes, injury to the shoulder and sometimes tear in these cuffs. So basically, when you are doing a robot, just remember that you are the master, it is the slave. So if you get that sense, that is the most important. So it will do what you do. So you have to remember that I have a working envelope, and I have to work in this. And if it is not working, if my arm is going out because I have to move inside my field in the vision, just make sure to get it back to your working envelope. Use the clutch again and again. So that is the basic key, that maximize the work in the center. Don't hobble around. Don't try to be very fidgety and work, within, okay, I have 5 minutes to do everything. No, just come back, take rest, and, make sure that, you have to make a sustainable job for yourself as well. Of course, you're going to do a wonderful job for the patient. So these are some this was from a paper where you can easily see. So, we are not in live interactive platform here, but here in the first picture, the person is flexing the neck so much. And in the second picture, the person is hyperextending the neck so much. Even you can see the back. So these are really bad positions. But when we are talking, so this is the proper posture, between neck flexion should be able to 0 to 30 or 0 to 25 degree. This was a paper which worked on the ergonomics in the Da Vinci console. It was from Netherlands. They tried to actually measure all the angles in about 20 surgeons, and what they were measured, that the trunk, neck, and shoulder angles were out of the safe ergonomic zones. We'll not go into the typical details of the physics, but grossly, the console which we have for the Da Vinci right now, the viewer angle, it is set between 40 to 60 degree. Viewer height is set between, can move between 104 to 137 centimeters, and armrest height is 74 to 84 centimeter. The idea of these numbers is not, I don't want you to mug them up. The idea is that there are some dimensions which are fixed, or as designed by the Da Vinci. And when these, we put them in some calculation, so typically the Da Vinci console is designed for a surgeon's height between 163, which is roughly 4 to 185 centimeters. So if you have a long, very tall surgeon or very short surgeon, especially which is a problem with the female surgeons in States particularly, the console is not designed for them, and there is no correction as well. And ultimately, while they can adjust their head or they can adjust their foot, they cannot get everything ideal position. And that is what the current limitation with the console with the Da Vinci. And I'm not sure if Da Vinci is really working on these right now. Second thing is the chair. So normally in India, I spent 2 years in States, and we had a chair specifically designed by the Nightingale, which partnered with Intuitive. And so it has a, very resilient foam. It has a good fabric and durable, aluminum base. And it was ergonomically designed for the robotic console. I'm not sure how many in India would have this particular chair, but what we mainly use something similar we have in the OR, and that chair is not ideal, but we make, do with it. So that is something we have to be sure. If someone is going to buy a Da Vinci, and, we can have a talk, that, how do we get this particular chair for the console? Now, another thing which is, very less discussed, and it's too much of physics, I'll not go in details, but grossly what you say, visualization ergonomics. So this debate starts from, open console versus closed console. So there are certain things when you're doing a surgery on a robotic system. Of course, the exposure is better, the illumination is good, the surgeon has having the camera control, that is better. But there's certain angles like vergence, accommodation mismatch, visual perception mismatch, visual vestibular mismatch. I'll not go into details of this, but it is something to do that when you are operating on a robotic console, how much you are able to, see, focus, and at the same time, you have to take help with your cues and your assistant, that what is the perception and how the tissue feedback is coming to you. And if we don't know a lot about it, it just causes the dry eye and the visual fatigue. Now, a very common debate, open console versus closed console. So open console, better verbal and normal communication. You are connected to the room. We are not gazing yourself into a closed dead space. So communication is better. You have improved camera control because you're always seeing in that. You have less reliance on visual cues for haptic feedback. And, open console is better for the spine because you're going to straight straight. Your neck doesn't need to be flexed into that console. So you're from visual point of view, ergonomics point of view, open console is better. But then there are certain things which you have to, make sure which happen, which are concerns with the open console. You have to wear the glasses. They come with the weight itself. Second, you have a decrease the brightness when you're wearing the 3D glasses. Now gaze. So there are two gazes: horizontal gaze when you're seeing straight, and down view gaze when you're seeing little low. So in laparoscopic ergonomics, when you talk about the gaze should be within that 15 to 20 degree down gaze, and it has been found that down gaze is slightly better than a stiff horizontal gaze, because horizontal gaze gives more pain to this and stress to cervical spine. And of course, when you're doing these things, your stereopsis might a little bit alter. You might have a little more visual fatigue from that point of view. But so it's not that open console is like the best console. Both open and close have their advantages and disadvantages. And this enhanced surgical system, it is very interesting because what they have done, so they are tracking your eye movements using the infrared system, and the camera moves with your eye. So that takes away the additional control, and as you are operating and as you're doing, so that is one thing which is new, innovative in this visual ergonomics. Of course, Versus and Senance are both trying to give you some sort of haptic feedback. Hugo has got two monitors, which becomes a little complicated for operating in ergonomics, but once you get used to it, doesn't actually matter a lot. Then we always talk about ergonomics for the console surgeon. We forget about the assistant because he's generally a trainee or a technician, but that is equally important, And there was a paper in 2019 itself, like 73% of robotic assistants were actually uncomfortable in their position. 20% actually had pain or visible bruising, and they are struggling with the arms. They are finding their way out, and so they're clashing with the arms. So it mainly affects their lower arm or the forearm, and tissue traction. It's the highest workload is happening there. So the assisted ergonomics mainly match to the ergonomics of a laparoscopic surgeon. So you should have optimal table height and monitor heights. I'm not going to discuss the laparoscopic ergonomics, but a very important point which we all should remember for assistant ergonomics and as well for surgery is the port placement, that minimum 8 centimeter difference, strangulation, remember of the fulcrum effect, and always there are some clearance controls on these arms from which you can make the space between these arms, that not only prevents clashing for when you're operating, but also it gives space to the assistant on the bedside. And so I think we know the problem, we understand it better now, especially in robotics. And so what is important? First thing, as Dr. Hemant rightly said, it is the awareness. You should be aware about it. You should be, of course, physically fit. And the third most important thing is micro breaks or maneuvers. So awareness is the key role. You should embark on this early in the training. So when I was doing my fellowship in robotics in States, then I actually learned about ergonomics and got involved because one of the professors was in yoga and he was doing some study with the ergonomics of the surgeons there. And so that is most important. Embark early, get to know about these things. Of course, stay fit. As a surgeon, we have a daunting task of doing long surgeries. So a good core strength training, and a flexibility always helps. And this is the most important thing, that is called the targeted stretching micro breaks. It has been systematically, as says, a lot of randomized control trials have been done, that you should take a break for 2 minutes every 20 to 40 minutes during the surgery. So most of the times when it was asked, how do you take the break? So the surgeon used to say either, suction, clean the camera, or, he will want some instrument which is not in the operating room, and he will sit for 2 minutes shouting on the sister that find that particular instrument. These are our inner ways of taking a break. We don't say that we get tired of we are taking a break, but we'll make some excuse. We take breaks. It is not we don't take breaks, but it is not a voluntary break. It is made like involuntary sounding to the OR. But you can make it voluntary. Tell them, like when we were doing cystectomies there, we used to take breaks between. So in a nutshell, that's the key slide when you talk of robotics and ergonomics, that the various angles, but mostly you should be comfortable. You should be just get aware that I'm not having pain in this my joint, or there should be no absurd posture, and that will always help. And I think with new robotic systems coming into place, of course open console is one of them, but they will be helping more and more with the ergonomics and robotic in the robotic designing. And I think that's from here. I'll just say thank you and happy to have any questions even now or at the end of the session. Thank you.
Thank you, Harshit. We will take the questions towards the end of the session, and meanwhile you can read the chat box also and read the questions whatever they are. Next, we will go to the talk by Dr. Ankur Mittal. He is Dr.
He's
Aditya.
traveling, sir. He's traveling, but he has given me the presentation. So I will be the sharing and running the presentation.
Yes.
But he has joined it. So Dr. Ankur, are you available?
Yeah, he and both Dr. Aditya
Yeah.
Sharma have got caught in travel. So anyhow, we will run the presentation and then please,
Ankur has joined. Ankur has joined.
yeah, stay with us and for the questions. Yeah.
So
Sure,
I'm
sure.
running.
Thank you, sir.
I am running the presentation. Thank you.
Good morning, everyone. At the outset, I would like to thank NZUSI for this opportunity. I will be talking on impact of ergonomics on surgical performance and patient outcomes. Ergonomics is the study of workplace design, and the goal is to optimize surgeons' performance and patient outcome. So let us see why it matters. Why are we talking about ergonomics today? The first most important is physical exertion. The morbidity to a surgeon most often manifests as musculoskeletal pain and referred as work-related musculoskeletal disorders. Numerous studies in the literature, they have defined the most common areas which are affected are neck, eyes, shoulder, arm, hands, back, and legs. Not only physical exertion, cognitive exhaustion is equally important. We as practicing urology takes a cognitive toll as well. Cognitive task load has been shown as a dose-dependent relationship with burnt out. It's surprising to see 2/3 of all experience a work-related musculoskeletal injury. Roughly half seek medical care, 1/3 reduce their caseload, and 1/5 miss work because of
The voice is lost at my end.
Even I can't hear.
No voice here.
important.
Always run it again.
Carry
And
out focus on making the healthcare facility itself easy and comfortable.
Yes,
Yes.
sir. Audio is visible. Audio audible or
No,
not?
no, no. It had come back. Just started again
Okay.
from here only.
And as per NABH guidelines, our ergonomic layout should include a soothing preoperative area, a staff adequately trained, no confusion and mixing the records and documents, identity and site of patient. Post-op area should have a nursing station facing the patient that with availability of emergency crash cart and CPR facility. What I feel is this facility layout is equally important and definitely helps us to improve ergonomics. If we see this operating room, what we can see here, multiple wires, less room space, and cluttered arrangement of machines. What are our objectives for an ergonomically sound OR? We need to minimize tripping hazards, maximizing view of flow, and ensuring adequate room space and controlling contamination. Let us see what are the solutions of these problems. The OR should look like this, what we call as a modular or integrated OR with no corridor tubes should be positioned across walking path, enhanced OR lights, large flat screen monitors, a motorized OR bed, short paths to obtain instruments and supplies and to access waste, definitely. A mandated planning briefing should be coordinated and include a cleanup duty assignments and equipment and tube arrangements, familiarization sessions for each OR equipment layout, and all OR personnel should be well rested. And how to prevent tripping? A thoughtful routing of cords and cable techniques, securing cords by bundling, taping, or braiding is equally important. Adequate space should be ensured. How it will help us? It will help us for unobstructed access to the patient, clear pathways for a circulating nurse. And it is said 600 to 650 square feet should be an adequate space for an OR which can be ergonomically sound. We talk about everything, but sometimes we forget about human resource ergonomics, which has an impact on overall. These 5 principles and guidelines, if followed properly, can have an effective work system design and have a good outcome for patient as well as surgical performance. So the human resource should be adequately involved to make a system approach, and they should be really considered for the relevant work. The active participation is important, and briefing and debriefing after the procedure is equally important to evaluate, train, and redesign the system. Ergonomic education is also a consideration because most of us, around 70 to 80%, have no prior training in ergonomics. Neither we are taught at our surgical training, and we learn bit by bit in our practice. Nearly 90% of residents and faculties and consultants, they report musculoskeletal disorders, and the solution for is that it should be a part of our curriculum in our surgical training. Certain things which are ergonomically more important is posture of a surgeon. The display monitor should be placed directly in front of surgeon and assistant. The upper edge is that should be in line of your eyes, and we should avoid prolonged standing and static posture, as we urologists, they have a long ORs. And how it can be done? It can be done by micro, rest, micro breaks, and range of motion activities, which we'll be discussing further. So, if you talk about OT table, whether we do open, we do lap, or we do robotic, table height adjustment is very important. And the consideration probably is our neck alignment should be in neutral position, and our shoulder elbow angle, our legs, and exactly this is more important. And as we see that in robo, what we see, if you sit and do a surgery, the neck angle should be aligned, and our elbow shoulder angle should never exceed, it should be in between 90 to 120 degree, and shoulder abduction should be less than 15 degree. And legs, we are seeing again 90 degree with knee joint. We use different instruments in all type of surgeries, open, lap, and robotic. I think what important is that if we think that we are working in a box means that our elbow, shoulder 90 degree, wrist should be straight, and we need to have a minimum abduction. Using instruments, I think open power grip is what is preferred by majority of urologists. And even if we are using an open finger grip, we should choose an instrument with finger holes that are large enough to fit the fingers comfortably, and avoid instruments or tools with high pressure contact area. Visualization in the OR is very important, and in open surgeries, we should really think of placing overhead lights, preferably two, which should be in between the surgeon and the first assistant. For laparoscopic surgeries, we should ensure room lights should be dimmed to reduce the glare and contrast on display monitor. And definitely in robotic, we are using 3D image for better visualization and depth perception. There are certain intraoperative devices which can be utilized to decrease surgical stress or urological stress and improve outcome. Anti-fatigue mat is one of them. These mats have been implemented in industries and recommended by United States Department of Labor, Occupational Safety and Health Administration, and have proved to decrease foot pain and overall surgeon discomfort. There are exoskeletons available. Personally, I'm not aware of any of these things, but when we are searching literature, they are there. These exoskeletons are external devices offer passive support, and there is a significant reduction in biomechanical demand and truncal mass ratio.
The voice has again gone.
Musculoskeletal disorder in our urologist. Exoscopes are there, which are available with high definition, high magnification, three-dimensional cameras. Definitely there is a first concern, but if it is available, it can reduce the ergonomically unfavorable neck and upper extremity pain. So with this, I think this is one of the beautiful example of improving ergonomics. Now after our flexible ureteroscope, we had digital chip on tip, and now we have disposable digital flexible ureteroscope, which definitely demonstrate lower forces required for deflection. Not only facility correction, not only OR correction, but ergonomics with technology is also an important role play. like our data collection, data recording, digital recording, record keeping, and data sharing. I think we should all be aware of these softwares which makes surgeons' life easy and also has an important role in patient outcome. Are there any devices who can assess the ergonomics, what we are talking about? These wearable technologies have evolved to include IMUs, which are sensors which are located in different parts of the body and accurately measure different body position angles. If you refer to this paper published in JAMA Surgery 2020, they have specified that most of the urologists, they spend 56% of operating time when they have used this study using IMUs with their neck in ergonomically high position. So see, unknowingly, we are in problem. We have discussed that taking micro breaks or range of motion definitely helps. I think these micro breaks are very important. These are short pause, typically less than 1 to 2 minutes, which can be taken intraoperatively and have a significant reduction in shoulder and hand pain. And complete team can take rest and micro breaks at that time, and then nothing probably have improved to increase the OT time. Range of motion activities for extension, flexion, rotation, left, right, stabilization of neck and shoulder, yes, can be done in these micro breaks. Between two surgeries, one can do these exercises of neck and shoulders for cervical and shoulder stretching, improving thoracic mobility, which definitely I think will be a help. And after this, all talking about physical load, the cognitive load we have discussed is also in relationship to it, and how we can decrease our cognitive load, because it is in subconscious level with every urologist working now, and which builds up in due course of time can have problems in future. So if we use a pre-operative briefing to coordinate our team, if we implement different checklists and SOPs in our day routine life, to employ read back, check backs, and cross training to develop a shared understanding, we include a brief pause in view of micro breaks and the range of motion activities, and definitely post any procedure there should be a debriefing and review to it. I'm pretty sure, and definitely following all those recommendations and considerations of ergonomics for physical task load, our cognitive load will come down to a minimum. If we talk about effect on patient outcome, sorry, sir, we don't have an answer in the literature. Data is lacking. But yes, what we know is that evidence-based urology is patient-centric, and ergonomics, which are related to surgeons' performance and outcomes, are definitely related to patient outcome. And improved satisfaction scores among patients will come if we improve the ergonomics related to surgeon and OR and facility. To conclude, I would like to say that we as a urologist now need to act on these unmet needs in ergonomics, which are ergonomic training, which we lack in our residency curriculum, need to be incorporated now. We should have formal faculty training of ergonomics, not only for the procedures, technology, equipment, and devices. We all have preventive maintenance as a part of our specifications when we procure something. But I think that preventive maintenance of those trained technicians should be utilized for our complete team at that point of time. Ergonomics advocacy and research in terms of making SOPs for surgical ergonomics and research is what is the need of our. Thank you, everyone, and thank you for your patient hearing. Thank you.
So thank you, Dr. Ankur, for such a nice presentation. Okay.
And thank you very much for playing it. Acha, Ankur was there, right?
Yes.
Okay.
So
So we are, I think Aditya has come or not?
he is not able to join, so because
Okay.
he is traveling. So anyhow,
So what I think we have got time for discussion, and of course we all can join in the discussion. I will put 2 points here. One is long back when I was operating in my OT. Suddenly, one of our senior pediatric surgeons, she's no more, although she came in my OT and stood behind me, and then she said, "Ajay, तेरी कमर ज़्यादा झुकी हुई नहीं है." That brings a very important point. If you have a dedicated observer off and on, not of course, it is not possible in every hospital, in every setup that somebody is observing you. But if some senior person observes the juniors regarding their postures and everything, so they can keep guiding them. That is one part of it. It is a very good thing. Second thing is there is see, when you learn surgery, everybody knows that there is a learning curve. But in every activity, even if you learn to drive a car, you will notice that your muscles are tense. So it is very important to learn to relax each and every muscle actively, intentionally to relax them. So you recognize whatever muscles are being used, they are still tense, and you actively make them relax. This is like Shavasana. If you know the Shavasana in yoga, to actively mentally recall you name a muscle that my ankles are relaxed, my shin is relaxed, my calf is relaxed, my thighs are. So you recognize muscle and relax them actively, intentionally. So this is a part of learning, because being tense is a part of learning process, and being relaxed is part of experienced, either driver or surgeon or anybody. So they are the two things which I would say. Anybody else, please add their experiences.
Dr.
Thank you, sir. Yes, sir.
Sajjad, Dr. Sajjad is also there. He does lots of URS and RIRS work. Dr. Sajjad, would you like to share some points on this? Dr. Sajjad?
Hello.
Yes,
Are you
yes,
hearing?
yes, yes.
Yeah. Actually, we started the RRS in 2019. And once I was doing a lot of these RRS cases, then I started with a pain in the back. It was
Mhm.
so much pain that I have to take a rest for a week. Then I realized it was once because of the right-handed, you are putting this whole of the weight on the right side, right of the foot. Because once you are using the laser by the foot, the whole of the weight was coming on the right side. So initially we were not knowing what's going to happen, but ultimately we thought that this is the ergonomics which has led to the musculoskeletal disorder, and then we take a lot of medicine, and then I recover it from it, and I'm using it. Especially then you change your hands, and then you have to put your weight on the both foot, and you have to keep your spine erect. That is the advantage. Then we came to know what is happening. Initially, we used to do with the endoscopic that without an endovision. So a lot of people have used to have a cervical spondylosis. After coming the endovision, which came, so it reduces that also. But RIRS and this thing, one has to be very sure, because you are putting the uh, X-ray jacket that in a lead apron, that too adds to the weight on it.
Yeah, it's good that you bring all these minor points which often get brushed and in fact go unnoticed, and the surgeon suffers because of these. I remember one of our senior consultants, I won't name, when I was doing MCH, would go actually for getting physiotherapy treatment in between the cases. And I wondered at that time what is happening and why doing that. But later I realized that the performance of the surgeon really gets hampered if the surgeon is himself in pain while doing the surgery. I actually have seen Dr. Mani Menon when I went to him for the fellowship. He actually has a massage chair in his theater. And in between the cases, or sometimes even during the case, he feels the stress on his own muscles. He would get a massage on the chair, wait for five minutes, and then restart. So that is the level of impact that the surgeries can have on the health of the surgeon. And in fact, in PCNL, we missed the talk of Dr. Aditya, but we have Dr. S.K. Pal here. Maybe we can take his comments, because PCNL is another surgery where the surgeon has to actually work with the load of 7-8 kgs of the apron during the entire case. And if you are operating on the stag on stone, then you can imagine how much workload that the surgeon has to take. Dr. Pal, can you highlight some of the issues with PCNL? Sir, Pal sir. maybe is not that. So actually, when you are wearing the apron, even then it's not just about taking the weight on the apron. There is a proper way how the apron should be worn. The lower sleeve with which the Velcro gets attached has to be tight enough so that the actual weight of the apron gets distributed to your pelvic girdle on the spine, and the shoulders don't have to take that much of a weight. Otherwise, what happens is the entire weight being borne by the shoulder, the upper neck and back muscles get sprained by the end of the surgery, even if the surgery is short, say half an hour. So that apron should also be worn in a proper ergonomically suitable manner.
Can I come
Any
in over
comment on
here?
this?
And one
Yeah,
one more
Rishi,
thing.
can I say
Can I-
something?
yeah.
Please.
Yes, Rishi, can you hear me?
Yes, sir, please.
Okay, so it is the weight of the jacket, that is one you are holding, and when you are doing stag horns, then it is the weight is transmitted to your knee joints. And even after doing several stag horns, many a times the knee joints, the legs get numb, and the knees they suffer. So the best way is that keep on flexing and extending your legs. That helps in between in a staghorn case. That is one thing I would like to say. Another thing is the collimation. And collimation is another very important thing because the radiation injuries, I don't know whether we have covered this topic, but there is a definite risk of radiation injuries to the body, especially the areas which are exposed, and they come again under image intensifiers. So I think everybody knows that I suffered radiation dermatitis, which was not healing, and I had to undergo this plastic surgery to remove all the this thing, skin. So thing is that one has to understand the problems which may take place with the equipments, machinery, and excessive use. Because in the young age, we are always committed to do more and more, but then we don't have a balanced thought process. And therefore, one has to define, because internationally, if you see, as Dr. you talked about Dr. Manimenon and all, they limit their surgeries to the professional way. But here in our country, still we don't have a professional way of limiting our surgeries. So I think the time has come that we should be able to emphasize our friends and colleagues that this is the limit, that choice is theirs, obviously, but then we should have some yardsticks so that we cater to the health of the young generation or the future generation.
Unfortunately, Anil, surgery एक नशा हो जाता है, especially in our situation. You have to show that you are the busiest person, so more cases makes you a bigger surgeon. So I mean, we are in a wrong way
I
of
agree,
we are
fully
in
agree.
a wrong way of competition. Another thing in PCNL, Kamal, I'll call you. I've seen your hand. Please just you speak when I finish. So another thing in mini PCNL, what I observed is when you are pressing laser foot pedal, so your main weight is on the other leg. So because in mini PCNL you have very long, 1 or 2 or 3 minutes of continuous pressure, continuous press of the foot switch. So by that time you are standing on one foot. So your heel also gets into pain at that time. So Kamaljit, please.
Thank you, Chairpersons. Thank you, Nordson. One small comment I would like to make regarding the PCNL is because I have personally suffered this and I have learned it the hard way is whenever you are wearing the lead apron, before you wear the lead apron, please hold it once. It should be very well padded on your shoulders. It should not slip beyond your shoulders in any way. When you're doing a long surgery, make it sure there is couple of sheets, dry sheets, which are placed below, because once the floor gets wet and you're putting weight on the single foot, the chances of you slipping or having a back strain increases drastically. Make it sure that after every 30 minutes, you ask the OT assistant to remove the sheet and put a couple of sheets more there, because you see it whenever you're doing a staghorn, you're always tend, your feet are wet and you always tend to, there is a tendency to slip. and you push your 1 feet close to the table and you try to snugly fit it so that you don't slip. This is where we go very wrong on the postures. That is the only comment I wanted to make.
So thank you, sir. So I think
There is one comment in the chat box also, which says that the two-piece lead aprons are available, which the puncture surgeon.
Can I come in over here, Rishi? Can I come in over here?
Yes, please.
So I started with single piece lead aprons, and then I just realized if the hospital is willing to spend a little money extra, two-piece lead aprons take off 70 to 80% of your load on your hip girdle. And they have straps also which can be kept on your shoulders. So one thing that you need to go ahead with the two-piece lead aprons, and they are far lighter than the single-piece ones with similar efficacy. And number two, like we're talking about teamwork in laparoscopies and robotics, where multiple surgeons operate. So if there were to be like a division between a people of two surgeons in one team, one takes puncture one time and goes out, and the other one does the staghorn stone without the lead apron. So you just see how we can and the next time they can do it vice versa. So they keep on doing their surgeries, they keep on getting their exposure, and yet they keep on protecting their body.
yes. So thank you. I think if there is no any other comment, we should move because one of the next speaker. Yeah, sir, come on, sir. So we can continue the second session because one of our guest speaker is basically he has some surgery to do and he has to rush to BLK hospital. So probably yeah. So we'll take this discussion after the second session. Yes, sir. So with Rishi sir, can we move to the second part of this webinar?
Yes, please go ahead. Dr. Yadav also wants to make a comment. Maybe after this talk, we'll take all the comments.
Yeah. So so moving forward. Okay. So the second part of the session is basically related to the management part and 1 second, let me open it first.
So,
okay, so second part of the session is management part, and in this we are discussing the practical strategies for ergonomic injury prevention. And in this session we have two guest speakers. The first one is the Dr. Vinay Agarwal. He is a senior consultant, orthopedic and sport medicine, sport injury specialist. And a second talk is by the Dr. Shipra Chaudhary. She is professor and head of department in PMR at Ram Manohar Lohia Hospital, New Delhi. And the third talk is by Dr. Kamaljeet Singh on some insurance related activity. So for this session, I would like to invite our chairpersons, Dr. Manu Gupta, Dr. S.P. Yadav sir, Dr. Manav Suryavanshi, Dr. Anil Varsne sir, and Dr. Anish Kumar Gupta. So chairpersons, you can just call up our first speaker. Dr.
Thank you,
Vinay.
Dr. Umesh. Thank you, Dr. Umesh. Very warm welcome to everybody. Dr. S.P. Yadav, Manav, Dr. Varsne, Dr. Anish, everybody's here. So right away, I invite Dr. Vinay Agarwal, who is new to this forum, to let us know how to make the right diagnosis for all these musculoskeletal injuries that we encounter in our urology practice. Dr. Vinay.
Thank you, everyone. Thank you, Dr. Umesh. Thank you, Dr. Hemant, and thank you to chairpersons for inviting. So I'm a basically outsider. I'm an orthopedic surgeon among the esteemed urologist. So I'll probably try to give, so my talk is basically diagnosis, but I'll try to give you a, a brief outline on the pathophysiology and what actually the biomechanics of injury while we operate. So can I be allowed a screen sharing, please?
Office, please help.
Sir is the co-host, sir, so he can share.
Okay.
Is my screen visible?
No, not yet.
Unshare the screen. I think the last speaker may unshare.
We have unshared.
We are not seeing anyone's screen at the moment. You can share, Dr. Vinay.
So I need some, I think, rights for that. I'm already on my screen. Screen share.
You can
Not-
open the PPT first and then share it from the screen. Share screen. Dr. Vinay,
Yeah.
open the PPT first on the desktop and then share it from the this Zoom part, share screen part.
I need to make a co-host for that, I think, because it's not giving me the option.
You
Zoom.
are co-host. You are co-host.
Just 1 sec. Okay.
Yeah. Yeah, we can see the your desktop view now. Yes. 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 Please make the PPT presentation.
Okay.
Thank you.
Yes,
Yes.
yes.
Please.
Yeah.
Fine.
So first of all, I'll start with this video, which will just give us some boost on this lovely Sunday, holy morning.
Audio, is there an audio also?
Are you not? Am I not audible?
Oh,
No.
no, no.
No, you
Video,
are audible, but the movie is not audible.
video is not audible.
Video is not audible. Now?
Yes.
Okay.
Music
Yes.
is
So basically, this video highlights, the kind of adrenaline rush, the kind of equivalence we have as surgeons compared to athletes. So we have the same kind of nasha. One of the esteemed speakers was calling the word nasha. So there is a nasha in surgery, which we all know how it is, and that's the same nasha as any athletic activity or any sports person has, because it's a pleasure we derive from our work. And when this pleasure, we have the same kind of stress, we have the same kind of injuries, we have the same kind of stresses which an athlete faces in a different manner. So coming back to ergonomics is derived from two words: ergon, which means work, and nomoi, which means natural laws. So ergonomics is science which studies the adaptation of human body to workplace and making the best fit to work. So ergonomic injuries are classified in our literature as work related MSK disorders and WMSDs, which are of three types. One is cumulative trauma disorders, second is the repetitive strain injuries, RSIs, and third are the overuse injuries. So basically all of these are soft tissue injuries which occur gradually. So when I basically started my orthopedic practice long back, we were, as a trainees, as junior residents, as PGs, we were basically dealing with fractures. And I thought that our was the most demanding job because we were dealing with hard bones. Over the period of years and years of training and fellowships which I had, and then I think my 60-70% work is now soft tissue, like ACL surgeries, shoulder surgeries, rotator cuff. So now I can really empathize with general surgeons and urologists that how difficult it is to handle soft tissues. It is much difficult, and it is much stressful to handle the soft tissues, because a lot of sustained hard work goes in, compared to a fracture surgery. When I do an ACL surgery, it requires a lot of soft tissue instrumentation and all. Secondly, with the advent of minimal access surgeries, there is a lot of it's a one-upmanship. Previously, there were a lot of people who were part of the surgical team in open surgeries, but now in all surgical specialties, whether it's orthopedics, general surgery, urology, or whatever, a lot of minimal access instrumentation have come. So we are doing a lot of arthroscopic surgeries, just like you guys are doing PCNLs and all these things, and robotics have also come. So all these things put a lot of load of all hands on one surgeon, because the surgeon is operating with his foot, surgeon operating with his hand, both the hands are occupied. So this leads a lot of occupational disorders of the soft tissues. So the soft tissues are muscles, tendons, ligaments, joints, blood vessels, nerves, and spinal discs or facets. So before we proceed further, we have to understand concept of work. So work is of two types. One is जो दिखता है and जो नहीं दिखता. दिखता is dynamic work, which like walking, talking, when you can see actually the hand movement or body movement. But surgical work is more, especially the minimal access surgeries work, are more of static work, like holding objects in one hand or in both hands with extended positions or in prolonged bad postures, like laparoscopic or arthroscopic surgeries. So these are static works because ultimately the muscles are working, but they are not. You cannot see the actual movement of the joints because it's static loading. So static posture refer to physical exercises when the posture is held in a particular position throughout the exertion. These types of exertions put a lot of loads or forces on the muscles and tendons, which contribute to fatigue. This occurs because of the impeding of the blood flow, and the blood flow is impeded because of sustained muscle contraction, because the blood vessels and capillaries run inside the muscles. When the muscles are in a sustained contracted state, they produce kinking of the blood vessels, and these blood vessels produce anoxic damage to the muscles and accumulation of waste products of metabolism. So static loading reduces blood flow because the muscles are not moving, that is contracting and relaxing. The constant muscle tension leads to swelling and pressure on the nerves, causing neuropathy. Static loading leads to muscle tissue damage, causing muscle strain, and also leads to tendon inflammation, where the tendon point of motion is restricted and swelling puts pressure on the nerves, which causes entrapment neuropathies. So physiology, one is that when the arthroscopic or laparoscopic surgeon uses one particular posture to hold the equipment, it is isometric muscle contraction. It produces, again, as I said earlier in the earlier slide, it reduces blood flow in the muscles. What are the physiological effects? Physiological effects are swelling and pressure on the nearby nerves. Static loading produces tears in the muscle and also produces inflammation in the tendons, which causes tendinitis. So you see, tendons are relatively avascular structures. So a lot of us among surgeons have a lot of issues with tennis elbows, wrist, painful wrist and all. Because tendons, once they get injured, they do not heal very well, and they produce a condition called as tendinosis, and that's why we have a lot of chronic pains. So for the physiology of repetitive motion, making the same motion repetitively can cause a lot of wear and tear of the joints, and the inflammatory metabolites, the damaging metabolites, they keep on building up because there is not enough rest periods, not enough blood flow between those areas. So these metabolites, they cause toxic damage to the joints as well as the muscles. So why is ergonomics important? Because we want to be healthy, we want to do longer surgeries, we want to have a longer surgical career. So these are the 4 points which produce discomfort. Awkward posture, sustained posture causes discomfort. Contact stresses cause discomfort. Repetition of any particular activities cause discomfort. And all these discomfort cumulatively causes musculoskeletal disorder. So these are the various positions of surgeons and various types of repetitive loading which I have taken from Google. Some of them are laparoscopic surgeons, some of them are arthroscopic, some are other specialties. So these are the incriminating factors which all of us face at some point of time. One is static loading, one is repetitive motion, one is extreme joint range of motion. Sometimes we have to do certain postures. We all know, and obviously when a surgeon is engaged in a procedure, they are least bothered about their own physical posture or physical comfort. We are focusing on that moment of the giving the best outcome. So sometimes we take the joints to extreme position. The joints to extreme position can be the wrists, usually the wrists or the necks. When we look at the camera for long hours, that's also taking the neck joint to extreme range of motion. Increased muscle tension, vibration, and awkward posture. So vibration, I'm not sure urology surgeries, but we have a lot of vibration when we do TKR and THRs. We have a lot of use of SAW. So vibration is a very important risk factor for hand injuries in orthopedic surgeons. So there was an article. So this was a basically pathophysiological study done on rat models and guinea pig models in USA. So this study outlined how repetitive loading basically damages the joints. So static loading and submaximal repetitive movement is the basically starting point. It causes anoxia and capillary endothelium damage, which releases the toxic free radicals. This leads to increased permeability and influx of monocytes, which in turn leads to proliferation of fibroblast and collagen deposition. This collagen keeps on staying and causes fibrosis in the muscle and collagen deposition. And then this, when the muscle loses the flexibility and muscle has a lot of collagen deposition, the fibrosis, this leads to the nerve entrapment, muscle state, and inflammation. So ultimately, it's an acute inflammatory process, just like any injury happens. But it's a chronic building process. Over a period of time, we keep on injuring muscles, we keep on causing muscle damage, inflammation. Then, whenever there is an inflammation, remember, obviously, we know from our pathology from MBBS years that whenever there is inflammation, there is influx of monocytes and deposition, body's repair mechanism is activated. But when this keeps on happening, the muscle loses its normal fibers and muscle starts accumulating a fibrosed muscle, which causes stiffness, lack of flexibility. And so when we feel the pains, when we feel that we have been now more less flexible when we started our earlier surgical career, all this is happening because our muscles are getting more and more fibrotic, they're getting more and more less flexible, and now the nerves which are traveling in these muscles, they are more prone to entrapment, because obviously a supple muscle, the nerves traverse easily. Now the muscle is harder, there are muscle bands, the nerve gets entrapped, and that leads to a cascade of phenomenon which we have pains. So these are two types of grips I want to emphasize. Most of us have jobs, have surgical, types of surgeries where we use a lot of instrumentation handling, especially the minimal access surgeries. So these are two types of grip which are commonly used, a power grip and a pinch grip. So you can see a power grip utilizes the long flexus of the forearm. Therefore, a power grip is 5 times stronger than a pinch grip. The pinch grip is entirely dependent on the short flexus of the hand. So pinch grip will be obviously less powerful and more demanding on the muscles of the hand. So this is the one taken from one of the studies where they were demonstrated how surgeons can try to improve the ergonomics. So on the number one side, on the top left, you see the power grip. In the middle is the pinch grip, and third is the precision grip. So it's not very, see, doing surgery is very difficult to keep thinking about our posture, our comfort. But there are certain habits which we can always, over a period of time, we change. We should change because some bad habits we develop from our surgical years, earlier training years, and they keep on living with us. Just like habits of lack of exercise or any bad habits. So there are certain surgical bad habits or posture bad habits which we have to self-analyze. So there was a talk. There was one chairperson who was talking that someone should analyze for you. That's also an option. But in majority setups, especially in private setups, you see, we do not have that much kind of manpower. Neither we have that kind of infrastructure and that kind of liberty to have people watching you. So I think more important is self-analysis, because when you know what things wrong you are doing, you may try to mend those, and especially when surgeries are less demanding, we have methods to alter our way of handling instruments. So supposedly, I'll tell you my example about using an arthroscope. So when I learned, obviously, when we are at earlier years of training, we learn whatever way we have to do this. So I used to do a precision grip or a pinch grip a lot, but then I realized that if I use a power grip also, using and handle the arthroscope that way, it doesn't really affect my surgical outcome. There are certain areas like going back of the meniscus, or where there are very fine areas, there I might use my more precision grip. But like shaving, all those things, so why waste my energy, and why not just even if it takes a couple of minutes more, but then it's more ergonomically handy to me, and I can do more surgeries, I can be less tired after each surgery. So सेल्फ एनालिसिस इज वेरी इंपॉर्टेंट. व्हाट मिस्टेक्स वी आर डूइंग, हमें जैसे कहते हैं ना, कारपेंटर को अपने औजार पता होना चाहिए. सो वी आर लाइक सर्जन, वी नीड टू be do a self analysis that what are our औजार, what are our instruments which we have to use regularly, and how do we use them. So they make some mends on those in our daily tasks. So what are the main ergonomic principles? Work activities should permit surgeon to adopt several different healthy and safe postures. Secondly, muscle forces should be done by the largest appropriate muscle groups available. So as I said, we have to do self-analysis. I know my forearm muscles are stronger than my hand muscles. So I will grip the instrument utilizing my forearm muscles more so that my hand muscles are relaxed. So larger group of muscles should be utilized. Then work activities to be performed with joints at about midpoint of the range of motion. So I will try to avoid extreme, if the monitor height is high, Then I'll ask my orderly or technician to lower the technician monitor height. Then and that can happen multiple times. It's not necessary that once surgical setup has been done, we cannot ask the technician to alter it. Supposedly there is one point where we need a higher height, or whatever. At one point we are at a particular position that we need we need to change the kind of monitor. Then that can be asked. The technician can do it for us. So that can happen within one single surgery also. Multiple positioning of the equipments, though not major positioning but minor. Now coming back to symptoms, we all know we have all of us have probably at one point of time must have experienced at least some of them: discomfort, pain, numbness, tingling, inflammation, burning, swelling, change in color, tightness, or loss of flexibility. So we all know how these symptoms feel at various joints. Now there's in USA and all, there is a very strong insurance network, and there is a very strong occupational department, which unfortunately India, and even in whether it's government or private setup, we do not have a proper occupational department, because we are never insured. We are not, no one, we can take a personal insurance, but we are never insured for any occupational health. But there is a proper system in the West, and they utilize, especially in the US, there is very strong, very good compensation network is also there, and they utilize this. One of the things they utilize is the REBA scoring system. It's a rapid entire body assessment tool. So it is a very simplified system, though it looks very complex in this chart. But it basically identifies 8 areas in the body. It has two scoring systems. One is the score for neck, trunk, and leg analysis, and the other is a score for arm and wrist analysis. So 0 to 3 of this scoring system, there are multiple parameters which is beyond the scope of this talk, but I'll probably just give you I'll just list through it. So 0 to 3 is a low risk, 4 to 7 is a medium risk, 8 to 10 is high risk, and more than 11 is a very high risk. So I selected this article to show that, very important, there was a study done which showed the risk of ergonomic injuries across surgical specialties. So this was a very small study. Obviously, it's not a meta-analysis or any major study was done, but yes, it was a good amount of questionnaire was done, and unsurprisingly, neurosurgery stops it. They have long operating hours, and so they were very high operating risk. Orthopedic, there is no urology here, but yes, I would say that urology and general surgery probably could be clubbed here. So 9 is a score of urology and general surgery, I would say, and then orthopedics is also around 9. In that way, ophthalmology is very good, as in they have almost not seen any ergonomic risk in ophthalmology, and other specialties are kind of at par with each other. Now, there was another data derived from this study, which was a correlation between the MSK pain and the years from surgical training. So you see, when we all start our surgical training, we post-graduation SRs, which is less than 5 years, I would say, so very high percentage, whereas more than 30 years is a very small percentage. Now, this data could be analyzed in various manners, because it could be said that obviously surgeon who has more than 30 years experience, they are not operating that much, or probably they're not reporting their risk, because it's a patient reported measure. However, what surgeons tell them. So obviously some surgeons would not like to tell about their discomfort. And younger surgeons, obviously, to please their bosses or to learn the skill, they may be more enthusiastic and do overt acrobatics during surgical during operating. So that could explain this skewed distribution. But I would say all of us at various years of training and various stages of training and various types of surgeries, all of us are at some degree of, I think, medium to high risk of, especially the minimal access surgeons, they are a high risk of having discomfort due to bad ergonomics. So this was again from this study only, ergonomics survey questionnaire. So again, multiple points are there, but I would say emphasize that cervical spine pain, neck pain is very commonly reported among all surgical specialties. And I would say that almost all of us are using a lot of monitors, sustained looking at particular postures and turning the head. And as I said in the earlier part of my talk, that this is a one man's MS surgery, MES surgery, minimal access surgeries are mainly one man jobs now. So almost all things are done by one person. So they put a lot of load on the arms and the neck, especially handling the instruments. And so neck pains are a very common finding among surgeons, across all specialties. And besides that, there is some degree of wrist pain, carpal tunnel syndrome. These are commonly seen in our OPDs also. I would say upper limb problems are really much more than lower limb problems among surgeons across specialties. So this is another interpretation of this study. The common sites of MSK pain, as I said, cervical spine tops the list. Then there are the limbs pain are also there. And there again, these are applicable to all specialties. So the problem here in making a diagnosis and giving anyone, advice is that doctors make the worst patients, because we know everything. Where people come to us for opinion, it is difficult to give people help or advice on something in which they are professionals, because they often feel as if they already know better than anyone else, and that's the problem with all of us. Because we have, all of us at some point of time have, felt certain problems, and then we have kind of ignored advices, whether they were right or wrong, and that's, it's very challenging. So treating doctors and advising doctors is very challenging. That's why I said more important is self analysis. हम क्या गलती कर रहे हैं हम खुद ही समझ सकते हैं, because advising surgeon is very very challenging for both ways. If you are a mentor, that till that time it is fine, but if you are a colleague, then it is a problem. If you are a senior, then it's a problem, or if you're a junior, then it's a problem. So I would say it starts from our Hippocratic oath, which we do when we got registered with the medical council. That first, do no harm, and this applies to us also. We should not do any harm to us. So common problems, I would just rush to them. They are tendinitis, common problem which we as surgeons we face: tendinitis, carpal tunnel syndrome, trigger finger syndrome, eye strains, hand-arm vibration syndrome, and lumbosacral or cervical strain. Investigative modalities are X-rays, MRI, ultrasounds, nerve conduction studies. See, we do a lot of sports medicine work, and a lot of sports persons come to us, and also my fellow surgeons who need my advice, they come to me. Ultrasound is magic, but it is very very operator dependent. So ultrasound, if you're a well done ultrasound, can almost pick up almost every kind of MSK injury, which even MRIs will miss. But the problem with ultrasound is that it has to be done by a very experienced person who has done a lot of MSK ultrasounds. So it's not a normal ultrasound. So simple, simple things which to summarize this talk. Simple things which we can adopt to avoid ergonomic damage. Bad ergonomics are adopting neutral posture while operating. Second is exercise guided micro breaks during surgery. That is 1 to 2 minutes micro breaks after every 20 to 40 minutes of operating time. So I was listening to one of the speakers, and they had a senior who was taking breaks during surgery, and that's the right approach. I think we end up with at some stage in our life, we'll end up where we have to compulsorily take a break. So before that, we should have a habit of taking some kind of breaks, which could be even like moving the hands, moving the ankles, just giving some micro breaks, improve the circulation so that the metabolites gets drained out. Then third is following good ergonomic neutral posture during surgery and ergonomically feasible equipments whenever possible. And that's we have to study. We have to do some homework in the operating room. So we enter the operating room only when we operate. So it's time that we enter the operating room. We see our setup when we are not operating, so that we know, we have kind of self analysis that how better we can use our equipments or instrumentations when even during the surgery. So management is the key. Use heavier equipments with power grip rather than pinch grip. Strength and conditioning programs for muscle conditioning. Regular exercises, yoga and stretching. Obviously, this cannot be overemphasized. We all know this. Future, there are a lot of studies. There is a whole entire departments being committed in some Mayo College and all UK US hospitals for more patient-friendly instrument. So we have talked about patient-specific instrumentation. Now the world is coming towards surgeon-specific instrumentation. Obviously, surgeons will have very high volumes of surgery will be the first candidate for these equipments, where the instrumentations are designed, customized for the surgeons. And eventually, when this spreads out, when the cost comes down, so I think all of us will have, because all of us have certain we are all different. Some are taller, some are shorter, some are, so OT tables heights, instrumentation designs are fixed. They are like one size fits all. But eventually, when the number of surgeries increase, when the number of surgical hours wastage increase, where when we take work off from surgeries, so patient-specific instrument, just like patient-specific instrumentations are there, we will all have surgeon-specific instrumentation. So these are some designs which are in the study state. Like this shows a ball, how to this one of the arthroscopic shaver, where we have a ball-shaped thing and we hold this, so that relaxes the short flexors of the arm and puts more load on the long flexors. So these are customized handle designs.
Yeah, Dr.
This
Vinay, can
is
we
basically future.
Thank you, Dr. Vinay.
Yeah.
Dr. Vinay, thank you very much.
Yeah.
I've just because Dr. Shipra is going to talk about minimizing injuries related to minimal access surgery. And we were very fortunate to have you here. Please stay with us for some question and answers later in the session.
So can we say do
Thank
the
you
question
again
answer
from the
now,
North
because I
Zone.
have a case actually. If
If
anything
anybody
wants
has
to
a
know, ask me
question,
anything.
uh,
I'll be probably leaving this after
So-
this talk because I have a case lined up. So I will be happy to answer anything now.
So from the injury point of view, when should one really start worrying and seek help for MSK injury? Are there any warning signs that something can guide us?
So warning signs are the workman hours lost. That's the main warning sign for us. I mean, because most of us, as I said, surgeons, we are a difficult breed. Basically, we are not normal people who will take medical help, because we are talking here about the elite group. We are talking about surgeons ourselves. So surgeon will be the last person to take medical help unless. So we have to, as I said, most important self-analysis. Are we seeing that we are regularly having certain pains in a particular surgeries? Are we have to skip? Do we have to skip? Are we compromising on surgical outcome? Or if not that, if are we not able to do number of surgeries which we were able to do earlier? Or it is our days are regularly painful. So I would say warning signs are again very again they're not ones, they're not fixed for anyone. It's a more of self-analysis. Certain warning signs can be regular neck pain, regular wrist pain, because most of the pains are nerve entrapments. So we sometimes certain surgeries we are doing very commonly, and then we start having a particular type of pain on a regular basis. So that's the time when one should seek help from a qualified colleague.
thank you, Dr.
And
Vinay. Thank
yeah,
you, Rishi. I think we
one
will.
last thing, Manu,
Mhm.
when we are talking about micro breaks, we should have macro break also. Like now he is
Mhm.
going to operate on
So,
Sunday also, so take macro
yeah,
break also.
yeah. So maybe it is an emergency, Dr. Vinay. Otherwise, it is not advisable to operate on Sundays. Okay. So I remember when people used to do open prostatectomies, once they used to remove the prostate, then pack, then go for tea, have their, lunch or breakfast, and then come back and then do the rest of the surgery. So we move on to Dr. Shipra, who's again new to this forum. Dr. Shipra Chaudhary, she will be talking about how to minimize the injuries in minimal access surgery. So Dr. Shipra, please introduce yourself also to us. Is Dr. Shipra there?
Yeah, please unmute Dr. Shipra.
Is there? She's there.
Hello, good evening, everyone. Good afternoon, everyone. I am Dr. Shipra. I am professor and head in physical medicine and rehabilitation. And I'm thankful to the organizer and especially Dr. Umesh for giving me opportunity to speak in this wider subject. We recently had a workshop in our institute and the conference, and we felt that was a very urgent topic that has to be discussed because the surgeons are facing quite a lot of musculoskeletal problem. So I'll be starting with my presentation. And although most of my presentation has already been covered by most of the speaker, so I just messaged Dr. Umesh ki what am I going to speak now? I shall try to cover the bits and pieces which were important.
Ma'am, please share your screen.
Oh yeah, I'm just trying to share. Is it visible? Is my screen visible?
Yes, please go ahead.
Okay, I'll continue with my presentation.
Make it full slide, please.
Okay. Now we have been discussing about this ergonomics since morning. Why it is important? Because poor ergonomics increases the risk of musculoskeletal injuries among surgeons, and it can also lead to physical and cognitive symptoms, as well as other health complication. Because as a doctor, as a surgeon, your focus is directly on the patient, and sometimes we are actually not aware of the recommendation or the guidelines designed to provide comfort while operating. So it may impact surgeon's performance. So what could be the issue? How can the musculoskeletal problems arise? Because they can be incorrect posture, improper visualization, and the stress which may lead to all these problems. Posture can be due to improper monitor placement, improper operating table height adjustment, and improper hand and instruments. Visualization can also affect task performance, can cause eye strain and cause musculoskeletal problems. So one of the very important point is the stress. It can manifest in many forms like excessive fatigue or musculoskeletal pain. And it could be due to the time pressure, equipment problem, poor OR layout, new technology, or unexpected challenging patient. And it can be due to the conflicting goal as well. So what are the possible solutions? It can be intraoperative solution that can be done in between the cases, and something which is being done as a long-term prevention and maintenance. So possible solution for the intraoperative solution, it has to be done for the monitor placement, operative table height adjustment, hands and instrument, visualization and stress. Stress can be taken at the end, and many of the things have already been discussed, so I will skip the slides in between. We all know the display monitor has to be placed directly in front of surgeon and assistant, and the upper edge of the display should be at the eye level. One important thing which you all should do is avoid prolonged static posture by incorporating simple range of motion exercise or stretches during the microbreak, which we have been talking about for quite some time. Every 30 to 60 minutes, you have to move your neck in flexion, extension, right and left rotation in between the surgery. Other exercise which you can do is deep cervical flexors training. So while you are actually washed, you can just feel like you are trying to do yes and feel the stress strain over your flexors of the neck, and then release and repeat it 10 times throughout the day. Apart from this, you can also do standing scapular retraction. Pull shoulder blades down and towards the spine as if you're trying to pulling your trapezius down from the ceiling. Hold the position for 5 to 10 seconds. Repeat 10 times. So for the operating table height adjustment, we all know it has to be adjusted as per the tallest person. And for the lap surgery, the operating table should be at the lower height than the open surgery. And for the robotic surgery, the arm should be adjusted to keep the surgeon hands near the elbow level. Use the clutches to bring both master controller to the center of workplace. And you have to choose the appropriate seat. That is very important for the console, and adjust to allow for the comfortable position of the feet on the pedals. There are certain important things like table height must be adjusted, which I've already said. And you, again, while standing, you have to avoid prolonged static posture, and you take microbreak every 30 to 60 minutes. In the picture, you can see on the left side, the surgeon is standing with his pelvis down on the other side. So on the right side, this is the neutral position, or you can, flex your leg and put it in the stool. That is a comfortable position. This has already been discussed that you have to try to work inside a box with the wrist, the elbow in the neutral position, wrist in the neutral position. Avoid reaching out to the end range of motions. Whenever possible, use body support to offload the board. Avoid static sustained posture. For the hand and instruments, there are certain general recommendations like avoid instrument and tools which have high pressure contact areas or sharp edges. Use trigger lock, ratchet, and other features to minimize the sustained gripping and squeezing forces. Use power grip. Visualize has already been discussed. There has to be proper light placement, which may lead to, if it is not placed properly, it may lead to the strain in the surgeon neck, because he may be trying to, to adjust his posture accordingly. So adjust the viewer height so that the user back is not crouching. Now there are certain solutions that has to be done before and in between the cases. These are, you have to pre-plan and adjust monitor location and lights, and you have to incorporate pre and post-operative stretches and stabilization exercise. These are certain exercises. You have to stretch your upper trapezius. You have to gently bring your ear to the shoulder with your hand place on the opposite hand behind your back. Hold this position for 30 seconds. Repeat 2 to 3 times each side. Another is levator scapulae. Gently try to look at your armpits. Hold this position for 30 seconds and repeat it 2 to 3 times each side. Now this is the pectoralis stretch. Place your forearm against the corner of the wall and step forward with the ipsilateral foot. While looking ahead, gently bend the left side of the forward knee. The contra leg remains straight. You do not have to hyperextend your lumbar spine, else you will cause strain there. And you have to hold the position for 30 seconds. Repeat 2 times on each side. Now, this is, there are certain exercises which you can do to improve your thoracic mobility. I don't know how much is the OT, I mean, how much crowded is the OT, but definitely you can do it in your surgeon rooms. You can use a foam roller for a thoracic, for the thoracic and lumbar mobility. Place the foam roller perpendicular to your spine and slowly roll up and down on the foam. Using your keeping your feet stable so that your back is arched, and you have to perform it for 1 to 2 minutes. And on the other side, on the right side, you can place the foam roller on your spine. I mean, you have to lie on the foam roller and then try to pull your shoulder back. And you can also do it 2 to 3 times. For the hands, you can do these exercises. You can do lumbrical stretch. You can start with flexing your proximal and distal interphalangeal joint, and then extending your thumb. Then keep it in the neutral position. Then flexing at the metacarpal phalangeal joint. Then again keep it back to the neutral position. Then try to make a fist. Then again keep it back to the neutral position. Then again flex your MCP, IP joint and abduct the thumbs, then again keep it in the neutral position. You have to do this lumbrical stretch every 5 to 10 times. There are certain exercises like passive wrist extension. With your arm flexed forward, your elbow extended, and your palm of the hand facing upwards. You can pull it and hold it for 10 seconds and relax. Repeat it 5 to 10 times. Another is keep your elbow flexed and palm facing upwards. Pull back your wrist and finger, hold for 10 seconds and relax. Other exercises, you can place your palm on the side of the wall with the finger pointing downward, stretch it and then relax and repeat it 10 to 20 times. Some of the surgeons, I've read that they keep the CTS splint at night to keep the wrist at rest. Now, their stress, that is very important. It has to be managed because, as I said earlier, it may impair the surgeon's performance also, and may also cause exacerbation of the musculoskeletal symptoms. Some things which can be done to reduce stress during surgery before and after is use a pre-operative briefing to coordinate the team, share the plan, establish coalition. Extremely useful for improving teamwork and operative flow and performance, and can be done in conjunction with the checklist. I'm sure you all must be doing that. Just to emphasize, use the post-case debriefing to review what went well and what went wrong. It is particularly useful when the team is facing problem with a certain, certain recurrent problem, and you have to implement the checklist. You can introduce brief pause during the operation and allow the team to refresh, check with each other if everything is all right. Adding interoperative exercise like group session is really good. Use prospective assessment to identify potential hazard before they have negative impact on surgeon cognition. Plan the introduction. Whenever you are planning to introduce a new equipment or technology, it has to be done with the most experienced team members. So for the long-term prevention and maintenance, follow the recommendation ergonomics guidelines for each type of operation. Establish a comprehensive ergonomic strategy for all operation, including table height adjustment. Establish an exercise and stretching program for the neck, shoulder, and low back. Consider seating surgery or robotic surgery. And grip strengthening and regular stretching of the hands can help maintain functional performance. You need to follow ACSM guidelines for aerobic strength and endurance training. Maintain calmness while operating in the operating room. Now, what is ACSM guidelines? It means that all healthy adults who are between age to 65 years age group, I mean us, should participate in moderate intensity aerobic physical activity for a minimum of 30 minutes on 5 times per week, or vigorous intensity aerobic exercise for a minimum of 20 minutes on 3 days per week. And every adult should perform activity that maintain or increase muscular strength and endurance for a minimum of 2 days per week. So these are some basic exercises which you can do while you are seeing the patient. You can, stretch your forward stretch, side bending, overhead stretch, shrugging your shoulder. Then you can do the trapezius stretch and the levator stretch, wrist flexion, extension stretch, overhead stretch. While you are sitting in the chair, you can pull your thigh and stretches on the opposite side, can extend your lower back, and you can just get up and shrug your upper limb to relax. So these are certain hand activity which a surgeon or any of the physician also should do it while they are at their workplace. I think that concludes my presentation. Thank you.
Thank you very much, Dr. Shipra. In fact, I would just like to tell you that I switched off my video and I was trying to do some of these exercises that you were mentioning them. I think many of
Okay.
you would be doing it at the same time.
Yes, sir.
Can we have a show of hands of how many people tried it while she was speaking? Also, next time, whenever you present, please make a short video so that we can, or put it on YouTube, because these seem very helpful to us. Thank you, Dr. Umesh, for calling Dr. Shipra. Big thanks to you also.
In fact, sir,
Any
Thank you, sir.
questions from?
Actually,
yes, ma'am, please.
no, I was about to say that initially when we had the session at a hospital, Department of Urology only conducted it. So at that time also we felt that just giving a didactic lecture won't be of much use. Then we thought that next time we are going to do a workshops that is hands-on. Then only everybody would understand how we are supposed to do. I mean, if suppose you're trying to stretch, but your posture is not correct, then you may strain your other muscles. So thank you. Thanks a lot.
Excellent talk,
Dr.
Dr.
Shipra.
Chipra. I think
Hello,
I
Dr.
must
Shipra.
congratulate you for that. And I just had a small question in mind, that what percentage of professionals, especially surgeons, come to you for these stretching and physiotherapy?
Abhi to sir, for after we had that session, so many of the, I mean, not exactly surgeons, so many of the physicians also, they have consulted us for the rehabilitation management.
I am coming.
And may I say Dr. Mesh is one of them.
No, it's very good.
Actually-
I think we must find out time and go for at least 15 minutes to your own physiotherapy department. I think that would
Sir,
form
I
part
want to correct you, sir. I'm not a physiotherapist. I am a doctor, and I am
No,
we
agreed,
have a
agreed,
rehabilitation
but then,
department, not physiotherapy.
but agreed, but then physiotherapy is also stretching exercises, and that they train you and make you
No,
fitter
sir,
for
that is all right, sir. We do have a team of physiotherapists, and we have occupational therapists also. The occupation therapist would guide you regarding the work ergonomics also. So we have a whole team, sir.
Yeah, the
Thank you,
mindset
Dr. Shipra.
really needs to change.
Yes, sir. Thank
And
you, sir.
good, God bless
Thank
you.
you, everybody. Thank you, Dr. Shipra, for being here. Now we go on to the last talk of the session. This would be by Professor Kamaljeet Singh, who is a urologist and also a financial counselor for thousands of urologists all over India. And he is going to speak upon insurances in occupational hazards. So, Professor Kamaljeet Singh, please.
Thank you, Manu. Let me shift to the full screen. Is my full screen visible to everybody?
Yes.
Now,
Yeah.
yes,
Uh,
but it's a
Thank you.
little bit
Thank you
bloated.
also for considering me worth enough to speak on some topic. Actually, when Umesh told me about this topic, I thought it is a too small topic to be done. And by the time I made 10 slides, I realized that this is on a whole very big topic, and this is what we all need to know. I start with the first slides is a disclaimer. I'm not an insurance agent. I'm not a kind of an expert. I've acquired some knowledge. I'm a urologist by profession. I'm just sharing my knowledge with you and should not be taken in any ways as a recommendation. My main aim is to make you aware of what actually you all don't know about anything. These things is. Please do consult your insurance agents and do read your government books before you actually take anything of these things. This is more important for the people who are working in the government sector. We all know there are a lot of companies which are selling the insurance policies to us. I need not go into detail. Everybody is an expert. They have their own liking and disliking why they pick up a policy or not. And this is what we actually look at the policy. We only talk about all health, life, home, travel, accident, auto. And this is what is our actually the insurance thing is. Trust me, most of you will be having this thing is what the hell is there in this topic is. Today, I'm going to tell you something more beyond this also. Now, the most common occupational insurance we take is professional indemnity. For us, the occupational insurance is professional indemnity. That means हमारे साथ यही एक सबसे अच्छी चीज है. I'm going to skip this topic totally. I'm not going to even discuss about it. I'm not even going to discuss about the health insurance. The first thing you all must know is the work safety. Protect yourself first. Then only you can treat. Then only you can be a bread earner for your family. That's it. So your safety is the first. There are a lot of regulations which are laid down when you are working. Read them properly. We are prone to hazards, multiple hazards. So to cover that hazards, you should always be insured. A normal medical aim policy is good enough to cover you. Most of the things, most of you are either working in the government setup. Few of us are owning an hospital and we are running. So it is important for us all to it. Overall, we have to look for the health of everybody in our own setup. Then only the system can function properly. Now, if you put it in the Google is what is occupational hazards in the medical profession is everybody thinks is an infectious disease. This is the minimum you can have. The other things which we totally ignore are the accidents, explosions, fires, electrical part. There is radiation exposure. Now we just heard Dr. Anil Vashne sir telling us that he had a radiation dermatitis. So these are the things we need to do it. Then you are exposed to the chemicals. Now with the lasers coming in, these errors, these exposures, these hazards have increased. I still remember Dr. Anil Vashne, one statement during an operative workshop was that he was wearing a goggle. And somebody asked, why are you wearing it? So he narrated a very good thing is, why do you wear a seatbelt in the car? The chances of accidents are very less. So these are the protective gears which you all must be wearing. So this is where I always remember the things. Now, this is why we need insurance. We need to cover our medical expenses for anybody who's running a hospital like me, Dr. S.P. Yadav, sir. We have to cover their lost wages of the staff. Then there's the rehab cost. If somebody happens to have fractures, then many of your staff, though close he may be, you are likely to face a legal issue with him when it comes down to monetary terms. So for that, you need to have an occupational hazard insurance. Now, I will go to the parts of it. There are three things which you must know: workers' compensation insurance, occupational hazard insurance, and the group health insurance. My total slides are 20, so I've already done with the 10. So in the remaining 10, I'm going to just finish off the topic. Now, this is a worker compensation is a form of liability insurance that provide financial benefits to employees. Mark the word employees, not as for the employers, who suffer illnesses or injuries due to the workplace accidents. If you go to the occupational insurance, it's a broader term where you can have a group kind of an insurance. It covers more or less the same thing. The worker compensation typically covers the death due to the workplace accidents, medical expenses, rehabilitation costs, and lost wages due to disability. Like you can assume somebody falls from a construction site and he dies or he is disabled. So that is the Compensation Act. Or the occupational hazard insurance is more broadly used to cover every possible thing. Every possible thing is that includes the coverage to the damage to the property. If somebody falls, he pulls out something and your C-arm breaks on something, that is also there. There's a fire, you lose a couple of employees into it. So the damages which is done, that is also covered into it. That is somewhere like a hospital indemnity policy, which is going a little more than, and you cover a health into it. Work compensation policy is a legal obligation for everybody. Even if you're in a government setup, God forbid, if anybody sustains an injury, you are entitled for a compensation under Workmen Compensation Act, which is made in 1923. It's a big document. I'm very sorry I could not read the complete. It is a very time consuming. So this is one thing everybody should know: a Workers' Compensation Act 1923. Then what is the difference between an ESI Act and a Workmen Compensation Act? This is very important. ESI is for the employees drawing salaries under 21,000, and it is applicable to, depends upon from states to state, whether you have 10 employees or 20, that's the minimum criteria. But Workmen Compensation Act implies to everybody who's acting, whether you are less than 10, you're less than 5, whatever it is implies the employers have to take care of it. This is a legal obligation. This is by law, we have to know. Ignorance of the law is not going to do it. One of my friends ended up paying 30 lakhs to his driver when he lost his driver in a car accident. And this was a very big thing. Everybody should know a Workmen Compensation Act. ESI covers what is the difference between ESI and a normal health insurances. It covers everything pre-existing illnesses. It starts like in state of Punjab for the primary members, it starts after 6 months. For the secondary members, it starts after 1 year. For all trauma, it is from day one. Number two is insurances. We do have a lock-in period that you cannot claim for some time. Now, this is what everybody should, or what the corporate people offers it, and everybody says, "Ha, ye to bahut achhi cheez kar rahe hain." They give a group health insurance. Now, this is also, you need to understand what actually it is. It's a no monetary, this thing is, they actually cover your health. I'm not going to read all these things, and it only helps in retaining the employee, and it kind of like your institutes are doing something for you. Actually, they're bypassing that Workmen Compensation Act and try to put you here only that hum aapki health ko dhyan rakh rahe hain. 30% of the employees, actually, just hold on. 30% of organizations do not provide any cover to their employees and their families. So there are three forms of it: E, ESC, and ESP. E means we only cover the employee. The bigger corporates, they will go for the spouse and the children. So it adds S and a C. So it becomes ESC. When they put it into the parents, then it becomes ESCP. So these are the terms. Whenever anybody is joining any corporate, should read what they are giving you. A group insurance which covers these 3 points, or only it covers the employee. Now, we doctors, lawyers, teachers, accountants, bankers, and administrative executives are put in the lowest risk group. So we are in the lowest group. But the people who are working in your hospital, like the electricians, drivers, they are in the moderate groups. So you have to understand the factors. When the risk goes to the moderate side, your chances of having paying the premium are very, very high. So you should have an insured vehicle also. So these are how they calculate the premium. That's beyond the scope of the study. So how you choose it? This is given all over the net. You all have read it multiple times. It has been discussed in Euro Insurance Econ, multiple forums. So there's no point discussing. You have to find a policy which is at least you can get to your better, the next higher level institute you want to do. It should be on their panel list. These are the kinds of insurances what we are looking at. No point discussing about it. These are everybody we have discussed about it. It should be a kind of critical illness, disability, everything should be there. But don't forget, if you get injured during this thing, you are entitled for a Workmen's Compensation Act also. Inclusion and exclusion criteria should be always very thoroughly read. Do see what is covered in your insurance and what is not covered in your insurance. This is very important factors. 99% of health insurance do not cover the robotic arms. So now start shifting to to a policy where you do have these coverages done. That is the consumables part. I'm still, as I started, this is a very, very big topic. It's impossible to finish in 10 minutes. I was told by Umesh to finish in 10 minutes. So the time, as I know, is totally over. Thank you, everybody, for giving me an opportunity to speak.
Thank you, Dr. Kamal. Any questions from the co-chairpersons?
Excellent talk, Dr. Kamal. I think you have covered most of the topics in a very brief overview. The only thing is the co-payments, because majority of these insurances, they are covering the corporate insurances and all. Today, the people are worried about that they have to pay out of pocket, even if it is a cashless settlement. So, do you recommend anything that what should be the minimum policy for a specific thing so that the co-payment is minimized?
Sir, this all depends upon the basically what you ask for an inclusion and an exclusion is. Rather than including reading what is included into it, I say always read what is excluded out of it. The policy is. That's the most important thing is. The minimum policy which I say that everybody should have is the expense you are going to utilize for getting a bypass surgery in a premier hospital, corporate hospital, in a super deluxe room. So that turns out to be somewhere around 15 lakhs odd rupees or to maybe 20. So that is the minimum you should do it. Number 2 point is whenever you're taking a policy, tell him that I don't want to have a co-payment. I don't want to have a capping on the room rent and no capping on the consumables used and the advanced therapy. So when you ask this, your premium will suddenly jump up by 1,500 or maybe 2,000 rupees. And that's better to pay that 2,000 because otherwise there will be a rider of 10% co-payment. So if you have to pay 10% in 20 lakhs, so you can imagine that it may be good amount of money shall be out.
So my question to you, Dr. Kamal, is does Workers' Compensation Act cover both permanent and contractual employees or only a particular set of employees?
Anybody who is working in your establishment, whether he's a contractual or a permanent, it becomes your worker under the Labor Act, and under Labor Act, this Compensation Act is applicable unto you. Or the another way to have is have a legal format of at least 100 rupees or maybe 1,000 rupees stamp paper if there is any contractual worker on it, or you have given it to a, you can say a thekedar. Tell him that these employees will be under them. They will cover it. This is most important.
So my question was addressed to you because most of the hospitals nowadays like to keep doctors on contracts and not as permanent employees. So that means any doctor who's on a retainer clause would be covered too.
Yes, sir. Yes, they will be covered for any mishaps that happen inside the hospital. Let it be an electric, maybe a radiation, maybe a slippage, fracture. and anything you are entitled for a coverage.
And my question to you is that what we take is the health insurance. So broadly speaking, health insurance will cover all these work-related injuries, or we have to take some rider inside it?
See, all health insurance company comes with an exclusion criteria and a minimum lock-in period, like maybe 30 days or maybe 60 days, that you cannot claim into it. But the trauma is covered from day one. Unfortunately, none of the policies for the doctors ever describes what is included and what is not included. We take it presumed that everything is covered till now. I don't know
So,
too much details.
Kamal, health insurance, as far as is concerned, for anybody, exclusion is for 2 years for any routine thing. Only the emergencies are included in most of the policies for first 2 years. For
Sir,
any profession for that matter.
Sir, for the health insurances, there are lock-in periods for like gallbladder is not allowed for 2 years. Acalculous cholecystitis is not covered for the 2 years. But now the policies have started coming in, which are clearly having, they are covering a pre-existing illnesses. So whatever it is, sir, we have to be insured on the every possible front. Now, I just tell you one very different way of thinking the things is. I say when we go for the car insurance, we go for maximum 4 passengers. We all go for 4 passengers. Because if you add your 5th passenger, your premium goes up. And that is your driver. Unfortunately, an accident happens and your driver goes off. So that has to be covered. This is what happened to my plastic surgeon friend. His driver died and he had to pay 30 lakhs. Though the company also paid, but they went to the labor court and to get the compensation from him. So he had to pay more money out of his pocket then. So
how many passengers were there in the car at that time?
Two
only.
Two only. He was on the left rear seat when the accident happened.
So, sir, if we have taken four passengers, then driver will be included in the passenger, or he will be excluded?
See, compensation was asked under Labor Act. The compensation was asked under Labor Act. He had not registered himself for those things. He was ignorant about that law. So then he had to pay out of that 30 lakhs from there also. So you have to understand that the law is against the employers. You should also know the law because you are also working in an institute. God forbid you slip and have a slip disc and you have to undergo surgery and you're out of work for 6 months.
Yes.
Now you're out of work for 6 months. Your corporates will start saying, no, we are not going to pay you. But the moment you will say worksman.
That is why all corporates have the agreement as only consultant, and we are not their permanent employee. If you read anybody of us who is employed in the corporate sector, we are not their permanent employee. So it will absolve them from any responsibility in case we incur any injury or accident.
Sir, in fact, they write in the clauses, if we read the fine print, that in case you are incapacitated, they are only liable for 3 months of salary or your medical bill, whichever is less. And that is how they wash their hands. So I wanted a clarification on this because one of our colleagues has suffered the same fate. And we are all on contractual contracts now. And all the younger generations and people who would come out, no one is willing to offer a permanent employee clause. So what exactly is the policy over there? I think people just fade away.
Sir, actually, I'm being very honest. This is the Compensation Act. When I read it, I have started reading it. It was thrice I dozed off because it's a big document to read, actually. The inclusion and exclusion is the corporates do find a lot of way and they have big lawyers to defend them and they are able to get their ways out. What I know when I spoke to a labor commissioner long back when we had this problem was he said it whether you're contractual or you're full, if you put up a claim into them, they will have to pay you, they have to treat you and they have to give you a disability allowance. The unfortunate part is that the law which is very strong into is the EICC, ESI. So our salaries are above 21,000 and some states it's 30 is the upper limit. So we are way beyond it. So we are not covered into it because ESI, if anybody gets disabled and he's being is given it, he's an ESI deductee, he's paying for it, then he will be covered. So you are literally, you wash off your hands, you can do it. But unfortunately for doctors, we do not have these kinds of things. We do not have. I'm very sorry.
So
But
let me
yes,
just quote,
management
let me just quote one example over here. Dr. Vashne mentioned that he had a radiation dermatitis. If it is proven that it happens because of the Siam that he uses in the hospital where he's been working for 10 years, would he be
Yes, sir.
liable for compensation?
Yes, sir. Absolutely, he's liable. I'm saying, sir, didn't you knew about this thing, and that's why he couldn't get it. You can even sue the your organization if they are refusing to do is that they have not checked the radiation leak on the surfaces. See, I was talking about the lead apron when you said you wear a lighter lead apron. I say you should never wear a lighter lead apron because the coating over it has to be very good. Because otherwise you will have burning out of your internal organs,
Okay.
the important internal organs.
Okay.
So
Thank you, Kamal. Thank you very much.
I think the Manu is getting
It is
tired
my
of these
duty
things.
to. So what we can do is to actually go back and look at all our contracts. Whoever are on, in corporate hospitals can go back and look at our contracts and have a good discussion the next time we meet in the North Zone conference. So, Rishi, to remind us that we should have a session on this again when we have a conference. Thank you very much for this session. I'll hand over the mic to Umesh and Rishi to say goodbye and a happy Holi from me also to all of you.
Maybe we can have a comment from Dr. S.P. Yadav. He had been waiting for quite long some time.
Sure.
Dr. Yadav, sir?
Sure, sir.
Sir, you are unmute. Please unmute, sir. You are mute. So please unmute, sir.
Hello, am I audible?
Now it's okay, sir.
Yeah. No, it was a very, very, very good talk. I just wanted to comment for knowledge of everyone from my own experience when I started laparoscopy. There is the two culprit are the table height and the monitor. We somehow table height you can change, but height of the monitor, if you see, is fixed in every theater of ours. That is where I started thinking, and then we got the monitor mounted on the arm, like we have the lights. So now we have the monitor which is mounted on the arm. We can change the height according to the height of the surgeon, according to the BMI of the patient, and the convenience of everyone in the table. Because most of us with laparoscopy, they suffer with cervical injuries. Height of the table you can change, instruments you can change. Monitor is very, very important. When you do a TURP, you are sitting. When you do a laparoscopy, you are standing. And with robotic coming in, everyone says open console is very good. I also say open console is good. But I'm realizing, I think it is being talked too much. Even with open console, all the risks are there to spine. We have discussed many, many things. I'm sure this is going to help all of us to improve our working environment. And I think small little breaks, actually in surgery, the slow is fast. We must take in between. And thank you to everyone for attending. Thank you, Dr. Rishi, for organizing everything. And I hand it over to Dr. Rishi.
Thank you, sir. I would conclude the session by saying thanks to Dr. Umesh, who actually did the hard work on the background to bring all the participants together for today. We know that we need to bring in more awareness about this topic, although we all suffer because of it, but none of us actually takes it seriously enough to prevent such injuries. And I would also thank the faculties, Dr. Vinay and Dr. Shipra, although they have left, to have graciously joined us for today's webinar. As you all know, the next activity under NZUSI is going to be at Jammu, which is actually the physical activity. Till now, we were having our monthly webinars under the Raise and Rise initiative that we had started. But the next activity in the next month would be a physical midterm workshop, and I urge all of you to be there physically. And it is on the reconstructive urology, where we are going to demonstrate both the upper tract as well as the lower tract procedures, both in males and females. So with this, I'll conclude the session. Happy Holi to all of you. Enjoy your festival till we meet again on 6th and 7th at Jammu. Thank you very much.
Thank you.
Thank you, Rishi, and thank you, NZUSI USI, for a wonderful event, and happy Holi to all of you. Thank you once again.
Thank you, sir.
Thank you.